Welcome to a new video. Thanks for being here today. Let's see. For decades, heart disease was considered primarily a man's problem. Medical textbooks, research studies, and public health campaigns focused almost exclusively on male patients, creating a dangerous knowledge gap that has put millions of women at risk. Today, we're breaking the silence on one of the most critical yet overlooked health connections: the powerful link between menopause and heart disease. What you'll learn in this video could literally save your life or the life of a woman you love. While cardiac issues can affect anyone, the transition through menopause creates a unique period of cardiovascular vulnerability that many women, and even some healthcare providers, remain unaware of. According to the American Heart Association, cardiovascular disease is the leading cause of death in women, claiming more lives than all forms of cancer combined. Yet, despite this alarming statistic, the specific relationship between menopause and heart health continues to receive insufficient attention in both medical education and public awareness campaigns. What makes this knowledge so critical is the timing. The average age of menopause, 51 years, coincides with a dramatic increase in women's cardiovascular risk. This isn't merely a coincidence, as we'll explore today. Understanding this connection empowers you to take protective measures during this crucial transition period. As we dive into this important topic, remember that while the information shared is based on current scientific research, your individual health profile is unique. Consider discussing these insights with your healthcare provider to determine the most appropriate approach for your specific situation. Let's uncover the scientific truth about how menopause affects your heart, and more importantly, what you can do about it. The estrogen protection theory. What science actually shows. For years, doctors observed that women typically developed heart disease about 10 years later than men. This led to the estrogen protection theory, the idea that estrogen somehow shielded women's cardiovascular systems. But what does the science actually say about this? Research published in the journal Circulation confirms that estrogen does indeed influence heart health in multiple ways. This hormone helps maintain flexible blood vessels that can expand and contract as needed, supports a healthier balance of blood lipids, higher HDL good cholesterol, and lower LDL bad cholesterol, reduces inflammation in blood vessel walls, helps regulate blood pressure. A landmark study from the Mayo Clinic demonstrated that women who experience premature or early menopause before age 45 have a 50% higher risk of developing coronary heart disease compared to women who reach menopause at the typical age. This provides compelling evidence that the duration of estrogen exposure throughout life impacts cardiovascular health. It's important to note that estrogen doesn't completely prevent heart disease in premenopausal women. It just makes it less common. Other risk factors like smoking, diabetes, high blood pressure, and family history can override estrogen's protective effects even before menopause occurs. The estrogen protection theory helps explain why the rate of heart disease in women rises sharply after menopause, when estrogen levels decline significantly. However, as we'll see next, the story is much more complex than just hormonal changes. The dramatic cardiovascular changes during menopause. During the menopausal transition, your body undergoes several significant cardiovascular changes that have been documented through rigorous scientific research. Understanding these changes explains why this period represents such a critical window for heart health intervention. Blood pressure changes. Research published in the journal Hypertension has demonstrated that approximately 43% of women experience a noteworthy increase in blood pressure during the menopausal transition. This isn't just a minor fluctuation. Studies show average increases of 5 to 7 millimeters of mercury in systolic pressure, the top number. What makes this particularly significant is that for every 20 millimeters of mercury increase in systolic blood pressure, your risk of cardiovascular disease doubles. Even modest increases during menopause can have meaningful impacts on long-term heart health. Cholesterol profile shifts. One of the most well-documented cardiovascular changes during menopause involves your cholesterol profile. According to research from the Study of Women's Health Across the Nation, SWAN, women typically experience a 10 to 15% increase in LDL, bad, cholesterol, a decrease in HDL, good, cholesterol, an increase in triglycerides. This shift doesn't happen gradually over decades. It often occurs rapidly within the span of just 1 to 2 years, around the final menstrual period. This sudden change helps explain why cardiovascular risk accelerates during this time frame. Body fat redistribution, a fascinating but concerning change during menopause, involves how your body stores fat. Research published in the American Journal of Physiology, Endocrinology, and Metabolism shows that declining estrogen levels are associated with a redistribution of body fat from the hips and thighs to the abdomen. This isn't just an aesthetic change. It represents a metabolic risk shift. Abdominal fat, particularly the visceral fat that surrounds your organs, produces inflammatory compounds and hormones that directly increase cardiovascular risk. Studies show that for every 10% increase in abdominal fat, there's approximately a 20% increase in cardiovascular disease risk. Insulin sensitivity reduction. The menopausal transition is also associated with decreasing insulin sensitivity, which affects how your body processes sugar. Research in the Journal of Clinical Endocrinology and Metabolism found that postmenopausal women have, on average, 6 to 20% lower insulin sensitivity compared to premenopausal women of the same age and BMI. This change increases your risk of developing metabolic syndrome and type 2 diabetes, both significant risk factors for heart disease. The insulin resistance heart disease connection explains why women with type 2 diabetes lose much of their female cardiovascular advantage compared to men. If you're finding this information valuable, please take a moment to subscribe to our channel and hit the notification bell. We regularly share evidence-based health information that could significantly impact your well-being or that of someone you care about. Your support helps us continue creating content that addresses these critical but often overlooked health connections. The silent symptoms. Heart disease presents differently in women. One of the most dangerous aspects of heart disease in women is how differently it can present compared to men. This difference contributes significantly to the underdiagnosis and delayed treatment of cardiovascular issues in women, particularly during and after menopause. Beyond the Hollywood heart attack, research published in the journal Circulation reveals that while men more commonly experience the classic crushing chest pain during a heart attack, women are more likely to experience unusual fatigue, 71% of women report this, sleep disturbances, 48%, shortness of breath, 42%, anxiety, 35%, indigestion or nausea, 39%. These symptoms can begin up to a month before a cardiac event and are often mistaken for menopause symptoms, stress, or aging. A survey by the American Heart Association found that only 65% of women would call 911 if experiencing heart attack symptoms, with many preferring to contact their doctor instead, creating dangerous delays in treatment. Microvascular disease, the female pattern. While men typically develop blockages in the main coronary arteries, a condition called obstructive coronary artery disease, research from the Women's Ischemia Syndrome Evaluation WISE study shows that women more frequently develop microvascular disease, problems with the tiny blood vessels that branch from the coronary arteries. This difference is crucial because standard diagnostic tests like angiograms often miss microvascular disease. Women may be told their hearts are fine despite having symptoms. Different treatment approaches may be needed. The prevalence of this condition increases significantly during menopause, with studies indicating that up to 50% of women with chest pain but normal coronary arteries may have microvascular dysfunction. Heart failure with preserved ejection fraction. Another female-predominant cardiac condition that increases after menopause is heart failure with preserved ejection fraction, HSPEF. Unlike traditional heart failure, where the heart can't pump effectively, in HFpEF, the heart pumps normally, but is too stiff to fill properly. Research published in the Journal of the American College of Cardiology shows that more than 2/3 of HFpEF patients are women, and the incidence rises sharply after menopause. This form of heart failure is particularly challenging because it responds differently to treatments than the more common form seen in men. Understanding these differences explains why women's heart disease is often missed or diagnosed later when treatment options may be more limited. It also highlights why generic heart disease advice based primarily on research in men may not adequately address women's needs during and after menopause. 5 evidence-based strategies to protect your heart during menopause. Now that we understand the science behind the menopause-heart disease connection, let's explore research-backed strategies to reduce your risk during this critical transition period. 1. Optimize blood pressure management. Given the tendency for blood pressure to rise during menopause, regular monitoring becomes especially important. The landmark SPRINT trial found that maintaining systolic blood pressure below 120 millimeters of mercury rather than the standard target of 140 millimeters of mercury reduced heart disease risk by 25%. For some women, lifestyle modifications can sufficiently manage menopausal blood pressure increases. Reducing sodium intake to less than 1,500 milligrams daily has been shown to lower systolic blood pressure by 5 to 6 millimeters of mercury in salt-sensitive individuals. The DASH diet, which emphasizes fruits, vegetables, and low-fat dairy, has demonstrated blood pressure reductions of 8 to 14 millimeters of mercury in clinical trials. Regular aerobic exercise, 30 minutes most days, has been shown to reduce systolic blood pressure by approximately 5 to 8 millimeters of mercury. For others, medical management may be necessary. Research shows that women often respond differently to certain blood pressure medications than men, so discussing female-specific considerations with your healthcare provider is worthwhile. 2. Address menopausal metabolic changes. The insulin resistance and body fat redistribution that occur during menopause require specific nutritional and activity strategies. Research from the Diabetes Prevention Program found that just 30 minutes of daily moderate activity combined with a 7% weight reduction decreased diabetes risk by 58% in high-risk individuals, including menopausal women, specifically for abdominal fat reduction, which is critically important during menopause. A study in obesity found that strength training twice weekly was particularly effective at reducing visceral abdominal fat in postmenopausal women. Research in the Journal of the American Heart Association showed that consuming monounsaturated fats from sources like olive oil, avocados, and nuts, instead of carbohydrates or saturated fats, helped reduce the accumulation of abdominal fat. These targeted approaches address the specific metabolic changes occurring during menopause rather than following generic weight management advice. 3. Consider the cardiovascular aspects of menopausal hormone therapy. The relationship between hormone therapy and heart health is nuanced and has evolved significantly over the years. Current research, including the follow-up analyses from the Women's Health Initiative, suggests timing matters. Women who begin hormone therapy within 10 years of menopause or before age 60 generally show cardiovascular benefit or neutrality. Women with early menopause, before age 45, typically experience greater cardiovascular benefit from hormone therapy. The lowest effective dose and shortest duration necessary to manage symptoms is the safest approach. The North American Menopause Society's position statement indicates that for women with vasomotor symptoms, hot flashes, night sweats, hormone therapy initiated around menopause appears to have a favorable benefit-risk ratio for heart health, assuming no contraindications exist. While hormone therapy isn't prescribed specifically for cardiovascular protection, understanding its potential impact on heart health is important when weighing its overall benefits and risks for symptom management. 4. Implement female-specific cholesterol management. The rapid cholesterol changes during menopause require attention, but women's cholesterol management might differ from men's in important ways. Research in the Journal of the American College of Cardiology indicates that high HDL, good cholesterol, may be a stronger predictor of cardiovascular health in women than in men. Studies show that controlling triglycerides may be particularly important for women's heart health. Dietary approaches that emphasize plant sterols, 2 grams daily, have been shown to reduce LDL cholesterol by approximately 10%. For women who need medication, statins are typically the first-line treatment. However, a study in JAMA Internal Medicine found that women experience side effects from statins about 50% more frequently than men, highlighting the importance of personalized approaches and monitoring. 5. Prioritize stress management and sleep quality. Emerging research shows that psychological factors may impact women's hearts more significantly than men's. A study published in the Journal of the American Heart Association found that women with high stress levels had a 40% increased risk of developing heart disease. Research shows that depression, which often increases during menopause, is associated with a 1.5 to 2-fold increased risk of heart disease outcomes in women. Poor sleep quality, common during menopause, has been linked to increased coronary artery calcification and hypertension. Evidence-based stress reduction techniques shown to benefit heart health include mindfulness-based stress reduction programs, which studies show can lower blood pressure by 5 to 8 millimeters of mercury, regular physical activity, which reduces stress hormones and improves mood, adequate sleep, 7 to 8 hours, which helps regulate stress hormones and inflammation. These approaches address the interconnected hormonal, neurological, and psychological changes occurring during menopause that can impact cardiovascular health. Conclusion: taking charge of your menopausal heart health. The connection between menopause and heart disease is neither coincidental nor inevitable. It represents a critical health transition that deserves much more attention than it typically receives. By understanding the physiological changes occurring during this time, you can take proactive steps to protect your cardiovascular health. Remember that women's heart disease often presents differently, develops through different mechanisms, and may require different approaches than what works for men. This knowledge empowers you to be a stronger advocate for your health during medical appointments and to make informed lifestyle choices. The good news is that the risk increase during menopause isn't predetermined. Research consistently shows that women who implement targeted heart protective strategies during this transition can significantly reduce their lifetime cardiovascular risk. In fact, a study in the Journal of Women's Health found that women who maintained optimal cardiovascular health through menopause had an 80% lower risk of developing heart disease than those who didn't. Consider discussing the specific changes happening during menopause with your healthcare provider, as personalized advice based on your individual risk factors will always be superior to general recommendations. This conversation is particularly important if you have a family history of heart disease, experienced early menopause, or have other cardiovascular risk factors. Thank you for taking the time to learn about this critical but often overlooked health connection. If you found this information valuable, please subscribe to our channel and share this video with the women in your life who might benefit from this knowledge. Together, we can break the silence surrounding women's heart health and save lives.